Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. Mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York, 12402. For more information or to donate online, visit our website at mykcr.org. And good morning. This is Dan Gatis, and it is 7 o'clock a.m. We're with you 7 to 9 a.m. every weekday, and today is Medical Monday. Monday, October 18th, and 45 degrees here in Uptown Kingston. And we'll be right back after these messages.
Hi, I'm Steve Thomas for Habitat for Humanity Restore. Habitat Restores are nonprofit home improvement stores and donation centers that sell new and gently used furniture, building materials, and appliances to the public at a fraction of the retail cost. The Ulster County Restore at 406 Route 28 in Kingston needs your donations. Call our hotline at 845-853-7499 to schedule your free pickup. And thanks.
Screening exams for breast, lung, or colorectal cancers are necessary to detect and treat disease at its earliest, most curable stage. But you may have some concerns and questions. Answer your questions and ease your fears by visiting radiologyinfo.org. In addition to information on screening and wellness, you'll find more than 200 descriptions of radiologic exams, procedures, and treatments to help you prepare. Get informed and be prepared. Visit radiologyinfo.org, produced by the Radiological Society of North America and the American College of Radiology.
Every 17 minutes, Make-A-Wish makes the impossible possible. They tame dragons. They bring Saturn to Earth. They help superheroes save entire cities. They even make unicorns fly. All to give children the strength they need to fight their critical illnesses. Every wish takes muscle. Help us make sure every wish comes true. Join us at wish.org.
Okay, men, this is your time. Maybe you didn't choose this, but you're here now. You're gonna go out there and be an all-star caregiver. Cook, clean, be there emotionally and physically. You gotta dig deeper. Drive them to physical therapy, doctor's appointments, because that's what caregivers do. Don't give up. Show the world that you're tougher than tough. Caregiving is tougher than tough. Find the care guides you need at aarp.org/caregiving. Brought to you by AARP and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And thank you for being with us today, 7 o'clock, 7:03 a.m. right now, Monday, August 18th, and 45 degrees here in Uptown Kingston. You're listening to KCR, Kingston Community Radio, WGHQ 920 on your AM dial, 92.5 FM, and streaming online at mykcr.org. Talk Radio, 331-9255 is your number. Let's get to the on-air studio with Dr. Eric Stanberg.
All right, good morning. Welcome to this morning's show, Medical Mondays, October, 18th? 18th. Driving in, sun is not up yet, or barely up, so it's
little strings of fingers of clouds in the on the horizon is all you see.
And I see some school buses on the road, which is
the rosy fingers of dawn. That's what
the rosy finger.
Yeah, the Odyssey.
Who did that?
Every chapter of the Odyssey started with that.
We
woke up to the rosy fingers of dawn.
Really?
Yes.
And then you never know. I mean, did Homer write that, or did some translator throw that in? Over the decades, over the centuries. All right, so now we're starting the show with very high, lofty expectations here by quoting the Odyssey, and in a way, this morning's show might be an Odyssey. We'll see where we wind up. I'll be here until 9 a.m. I think I have guests coming in. They're so we're gonna keep some mystery going there, and Not quite sure where Ms. Baker is this morning. So we'll see what goes on with that, too. So I'll be here until 9 a.m. If you have any questions or comments about medical issues or our wonderful healthcare system or healthcare industry, 331-9255. I finally learned how to memorize. Well, I finally memorized that number after all the years, 331-9255. And anyway, so yeah, we like phone calls regarding anything, medical issues, medical questions. We talk a lot about the business of medicine because unfortunately you can't quite not talk about the business of medicine. So if you have any questions about bills or things that are covered and how they're not covered or things like that, it's also a good idea to call. So when I try to put together this morning's show, I always try to come up with various topics, and one thing I always like to share are kind of maybe some interesting cases that I've experienced over the prior week.
Days slip
over the prior week, try to kind of keep it in layperson lingo, but I think people do find these cases interesting, and when you're in the business, sometimes you forget they're interesting because you kind of see them a lot. So to the doctor, maybe they're not interesting, but to the patient, they're quite interesting. So we talk a lot about chest pain and things that might be concerning regarding chest pain, reasons to go to the emergency room. I think we tackled that subject a couple of weeks ago. So the case that I saw yesterday was a man in his early 70s, 72, 73, and he does have what's called so he's a male. So men have higher risk than women for cardiovascular heart attacks, atherosclerosis. There's many terms that get thrown around, but by no means is it unheard of in women. As a matter of fact, it's very common in women, but men do have a higher risk, and also as you get older, the risk goes up. He does also have some risk factors like hypertension and high cholesterol, although those are very well managed. He does not smoke. Family history has some heart disease in his parents. He came in with chest pain. And one of the things I talk about here is how important it is to just interview the patient. That's called the history. We call it taking a history. And then a physical to kind of also go along with the history. When I was a medical student resident, they were very separate, kind of took a history and then a physical. I usually do sit across from the patient, take a history, but when I start to examine the patient, I start to maybe ask them more questions that seem to come up as I'm going along. So it kind of like the line between what's the history, what's the physical, sometimes gets a little less well defined. So it's always very important to get the patient's story. I think it's one of the things we talk about in this show. And I think that's a common frustration with patients. They feel like they're not really, they barely get a sentence out before they're kind of like interrupted and kind of peppered with questions, or even maybe don't even get a chance to say much of anything about it. And another interesting theme in medicine is that we also, it's not that we don't trust each other, it's just that we kind of want to verify on our own. So patients will kind of get to ask the same questions frequently when they present to an emergency room. You start with the nurse taking a history, then the emergency room physician taking a history, and then if someone like myself gets called down to evaluate the patient, I'm going to ask the questions. We do listen to each other and communicate with each other, but every now and then we also just want to hear it from the source. Ain't nothing like the real thing. So this gentleman woke up yesterday morning with chest pain. And when we asked him questions about how to describe the chest pain, he said it was kind of a sharp pain, but it was constant and quite severe. And he felt that it was worsened by taking a deep breath, worsened by leaning forward. He also kind of had some numbness in his left hand and right leg, and I'm not really sure how that's related. Sometimes you just you try to put it all together, and every now and then you still have some loose ends that may or may not fit into the theory. He had already had what we call a full cardiac evaluation about 1.5 years ago, including a stress test, for example. So, generally it's pretty unusual to develop something over 1.5 years. I mean, anything's possible, but that's still a fairly recent history. His workup in the emergency room was, well, we used the word unremarkable. It was unremarkable. His labs were all normal. Blood tests that we do to see if someone's had or having a heart attack were normal. That's specifically something called a troponin. An EKG is a very common test that many people have had, kind of wires to the chest that was initially read as normal. First of all, we have a computer that reads it, and then we look at it ourselves. But because of his risk factors and the story, we decided to kind of keep him overnight for what's called an observation and make sure nothing's evolving. And I asked a cardiology colleague to see him, which is also common because this is the heart after all. So the cardiologist evaluated him, and actually, I misspoke a little bit. In his blood work, his white blood cell count was elevated at 15. Normal's about 11 or less, 10 or less, depends on how you look at it and what lab you're using. So 15 is elevated. And the rest of his exam is, there's no evidence that he has any infection going on. White blood cell counts are elevated when there's inflammation going on. So that could be an infection, but it could also be other things, an injury even, so the list is rather long. So the cardiologist felt that there were some slight abnormalities on his EKG, and then just kind of quite to the story, felt that he had a condition called pericarditis. So the basic anatomy of the heart, there's different ways to look at it, but you have the inside of the heart, that's called the endocardium. You have the muscle of the heart itself, which is called the myocardium, and you have this kind of like a tote bag. Imagine if the heart's put in a tote bag and then kind of like a little Ziploc, and that's called the pericardium. And it's kind of a layer around the heart. It's interesting because people have had heart surgery, open heart surgery. One of the things that, to get to the heart, you have to open up this pericardium. So it's almost like not really essential because you don't close it back up. Anyway, so pericarditis is kind of just inflammation around the outside of the heart. And it can cause rather severe pain. It can mimic something. Is it serious? Well, it's serious in the sense that it can make the patient phenomenally uncomfortable and cause a lot of pain. Is it something that's life-threatening? Kind of not. There are some subsets of pericarditis that we probably won't get in, but they are more serious. So it's just inflammation around the heart, and it causes a lot of pain that I kind of just described. Why does it happen? Most often, the cause is idiopathic. Have you heard that word, Dan?
Not idiopathic. Not recently, and not in context. So, yeah.
Idiopathic. First of all, we use that term a lot, and a teacher in medical school I had said that it means we're idiots and we can't figure out what's causing it. So idiopathic means it kind of just is. Patients say that a lot. Why is this happening? Why am I sick? And the answer is it just kind of happens. So the most common cause of pericarditis is really it just happens. There could be viruses that can do it. It could be secondary to another problem like pneumonia, where the inflammation can kind of like spread over to the pericardium.
Can that evolve into something more serious down the road, a few years later or something? Or is that kind of an acute thing that just comes and goes?
It could be a recurrent problem, which is quite upsetting to the patient. And I guess it can cause something called constrictive pericarditis. A lot of times these terms kind of sound complicated, but if you think about the terms we're using, it just kind of describes what's going on. So pericarditis means inflammation around the heart, and restrictive means it's causing constriction or restriction of the heart itself. Imagine if this bag with a tote bag gets kind of tied a little bit tighter, what's going to happen? That's really not that common, thankfully. And there, if you were to open up a medical textbook, you would probably see a lot of really obscure causes of this. A lot of it, unusual infections, tuberculosis, but, and a lot of other things. So the treatment is anti-inflammatories. The cardiologist that I was working with just recommended ibuprofen, and that's what we're treating the patient with, and we'll see how he does. At the same time, we are making sure that he did not have a heart attack, which he probably did not. Or part of the workup includes an echocardiogram, very commonly ordered test, kind of gets a picture of the heart. That's different than an EKG. EKG stands for electrocardiogram, so it's wires and kind of electrical impulse. It gets kind of a tracing that everyone will kind of recognize, because it's just part of our I don't know. If you saw it, you would go, yeah, that's the heart. You know?
Waveform. It's
Waveform, right. And the echocardiogram is an ultrasound. So you're looking at the valves of the heart, very important. You're looking at the walls of the heart. You're looking at how the heart is pumping. You get a lot of information from the echocardiogram. And by modern standards, it's not a big test. It's not a particularly expensive, by modern standards. It doesn't mean it's cheap, but it's not a very expensive test. So in his case, the echocardiogram it doesn't show much. Anyway, so what else could you do if the ibuprofen doesn't work? Steroids can be anti-inflammatory. They're sometimes used. And interestingly enough, this is a kind of a side note, but something called colchicine. Colchicine actually has another use, which is more common, which is gout. Colchicine works by just interfering with these, they're described as tubules that kind of like inflame and pull things together. We don't get the details with that. So this patient, he'll probably go home today, maybe tomorrow. I hope he's feeling better. But the reason I want to discuss it was just a kind of another cause of chest pain that might kind of come up every now and then. Someone might be diagnosed with it. The classic symptom is classic description is kind of a sharp pain that is worsened by certain movements, and sometimes by leaning forward worsens it. Sometimes the patient feels better by leaning forward. So it's just kind of one of the clues that you look for when you see the patient. All right. Anyway, that was my we used to call those when I was a resident. We used to have vignettes, and that was a vignette from yesterday. Little kind of case synopsis. I wanted to talk. We talked a lot last week about vaccines, because we were talking about the flu vaccine, and I meant to talk about something that made the news, and we're not going to spend a lot of time on it, but I did want to mention that the fact that a malaria vaccine was in the news last week. Did you hear that, Dan?
I didn't check it out.
Yeah,
I
mean, this is
catch it.
This is really fascinating and exciting and interesting. Malaria, it's not much of a problem for us here in the United States.
We've had treatments, but not a vaccine. Am I correct?
Right.
That is a sea change for most of the world.
It really is.
Yeah.
Malaria is an infection. It's caused by Plasmodium. These are actually multicellular. So by definition, they're not bacteria. Bacteria, by definition, are unicellular, only one cell. All right, so it's a couple cells. A couple other examples of that are Giardia, for example, is a couple other cells. Giardia is a kind of a parasitic intestinal illness that comes up every now and then. So malaria exists throughout the world. It's transmitted by mosquitoes. It's very common in warmer parts of the world, Africa, Asia, South America.
Where 3/4 of the population of the world live.
That's right.
Between the Tropic of Cancer and the Tropic of Capricorn.
Right, the tropics. And it's very common. And there's different forms that vary in severity, but in worst case scenario, it can be a fatal infection. We do have treatments. A lot of times we also have what's called prophylaxis. When someone travels to certain parts of the world, they might be a candidate for malaria prophylaxis, something that could be prescribed. But the idea of a vaccine, to kind of prevent this is a big story, and it kind of just shows you how important ongoing research is and how important vaccines are. One thing I wanted to talk about was the boosters, which is coming up a lot with patients. Boosters for COVID. We have 3 vaccines that are approved in our country. We have the Pfizer vaccine, the Moderna vaccine, and the J&J vaccine. Originally, the booster for the Pfizer vaccine was approved, but last week the booster for the Moderna was also approved, and I don't think the J&J has been officially approved yet, but it's probably gonna be. So one thought about the point about the booster vaccine. Remember, we're seeing a lot of breakthrough infections. The Delta strain was very upsetting and concerning over the past 3 to 6 months. We're actually seeing a little bit of a lightening up of it, which is good. But it's still most important that people who have not been vaccinated get vaccinated. Remember, the ones that are seriously ill have 90% of them have not been vaccinated. All right, so the booster is really to kind of help people who've already been vaccinated. And it's an interesting kind of a push-me-pull-you of the politics regarding it. The makers of the vaccine, they do have, it's an industry, so the more doses they are able to distribute, the more that they potentially profit. So they potentially have a conflict of interest to recommend something that may or may not be indicated. So that's where the FDA comes in. That's why this industry has to be regulated, because prior to the FDA, things kind of just happened, with potentially negative effects and outcomes. So the makers of the vaccine have to make the case to the FDA that this that the booster is necessary. So that's why it's taken time. And it's not a surprise to me that the booster is being recommended. And I think, some form of every 6 months or annual boosters, I think, may be recommended until this pandemic ends. By the way, I do think it will end. It's not going to be something that will go on. Like every year we have a flu season. Dr. Froud a couple of months ago came in and talked about the Russian flu of 1898. Very fascinating medical history. And he said that flu was actually a coronavirus because they were able to study it. And he said it really kind of went around for 3 years or so. Each go around a little less severe, because remember the immunity kind of increases with each go around. That's the whole idea of herd immunity, and then eventually just kind of peters out. A couple things different between 1898 and 2021. One is treatment. We have some specific treatments for the COVID virus that are quite effective, but that doesn't prevent transmission, so to speak. That just kind of helps prognosis. Unfortunately, we're a bigger world and we're a more mobile world. So if you look at 1898, for the most part, people just kind of stayed in their communities. Villages, even people who were in major cities like Moscow, they probably didn't travel too much around the city. You ever talk to my mother grew up in Brooklyn. They even, people who live in Brooklyn still talk about infrequently traveling,
even outside of your neighborhood.
Right, 5 or 6 blocks outside of your, so the fact that we travel more might affect this. Anyway, so I was talking about the booster and why we need it, because it's not really done yet. You remember there's kind of 2 reasons, maybe 3 reasons overall for getting vaccines. One is to prevent you from getting an illness. Number 2 is to mitigate an illness if you were to get it, make it more mild. And the third one is more of a communal or societal need, which is to try to control the spread of an illness throughout the community. So therefore, it doesn't travel so much. And that last one kind of requires us to step outside of ourselves a little bit and, think about being a citizen in this city and county and state and country and world.
And world, yes. Mm-hmm. I mean, how fast that variant got to the United States is shocking from India. And how fast it got from China to here.
That's right. There were whispers about more variants. I have not heard much recently. So let's keep our fingers crossed. Over at the hospital where I work, pretty much 100% of the admitted patients who are ill with COVID are unvaccinated. So just, again, when people say I'm waiting for more information, waiting for more data, I'm not quite sure what to wait for. I think that's pretty convincing data. 90% of very ill and hospitalized patients are not vaccinated.
Is it are the doctors able to, and the labs able to identify whether it's an original COVID or the Delta variant? And are there numbers in regard to what that entails and what that shows?
That's a good question, because it kind of does come up. The answer is no. I mean, when I test someone for COVID and even send someone out for COVID, it doesn't really specify if it's the Delta variant. First of all, it doesn't really matter. And I think it's a safe assumption that all cases we're seeing now are the Delta variant. It doesn't really change treatment. and it kind of doesn't matter. One thing that still comes up, and I know I kind of rehash subjects that we go over the prior week, is people want to have their antibody levels checked. The reason I find this not helpful and discourage patients from having it done are a couple. One is if you have been vaccinated, you're going to have antibodies. Okay. Number two is if you've been sick with COVID, you're probably going to have antibodies. If you've been sick with COVID and then got vaccinated, you're going to have antibodies. So the presence or lack of antibodies doesn't tell us much about whether or not you're at risk of getting COVID again. There is no agreement about the level of antibody that's effective, contrary to what you might read or what you might hear. When people, for example, enroll in college, they frequently need proof of immunity for measles, for example. And either we can locate the shot record, and if we cannot locate the shot record, we could check levels. Those are called titers. And it's well defined. Yes, this level of antibody, if you're at it or above it, you are considered immune. We don't have that consensus, knowledge, whatever, to conclude whether or not you're protected from COVID or not, based upon the level of antibody. And the test that I can order, I don't think even really gives a level. It just kind of tells if it's positive or negative. The other point is the immunity probably drifts downward as time goes on. We don't know for sure, but there are plenty of cases of people who got COVID again, people who got the vaccine and then got COVID, probably because of antibodies drifting downward. And that's kind of why we are talking about a booster now. But if your level now is okay because you kind of, I don't know, think it is, doesn't mean it's going to be okay in 3 months or 6 months or 12 months. So I don't find that a helpful test, and I really discourage people from.
It's interesting that the antibodies seem to fade for COVID, but for other diseases, the antibody seems to live forever in your body.
Yeah, it's interesting. Every
interesting.
Pathogen. Pathogen is defined as something that causes an infectious organism that causes disease of some sort. It could be a virus, it could be a bacteria, it could be a fungus. There's some other subsets of things that can do this. They affect us differently. Just like some don't make us ill at all, some make us mildly ill, some make us seriously ill. The immune response also varies. It could be kind of lifelong. Mononucleosis is kind of like that. You're really kind of only supposed to get mono once in your life. And a lot of people get it and it causes minimal symptoms or symptoms are, so they never even really had an accurate diagnosis. But if you were to test 50-year-olds, for example, they'd probably see almost 100% immunity. I have no idea. Some infections kind of live in you forever, which is one of the reasons why the antibodies are always positive. A good example of that is chickenpox, because chickenpox can live in you and then wake up again as in the form of shingles. Kind of almost like it's like a comic book, right? Or a horror movie.
It's like a horror comic book.
Yeah, where it's going to live in you forever and then wake up in a different mutated form.
Oh boy, is it! Good analogy.
Well,
and true with Lyme too. There's a certain residual with Lyme after you've knocked it out and you've gotten rid of the symptoms. Isn't there a certain residual of Lyme?
And it's a good point because it's very common. Lyme is common, okay? And I always tell people when we diagnose and treat it, the great majority of people are easily diagnosed and easily treated because I want people to understand that, yes, they have Lyme, but the great majority are going to be fine, really. And it's not even really particularly hard to treat. It's a course of doxycycline or amoxicillin for a couple of days or weeks. But you can get Lyme again, and People, so what happens? People will, for example, say, "Hey, can you test me for Lyme again in 2 months to make sure it went away?" And it doesn't quite work like that. Maybe I'll visit this subject after our first break. But yeah, the antibody levels for Lyme might be positive for the rest of your life. So the blood work is very difficult to rely upon. and you can get Lyme again. And so that's that's a very hard diagnosis. When someone, it's another season, another spring, people hike, they work in their yards or whatever. So we'll revisit that a little bit after our first break.
Thank you, Dr. Eric Stanberg, and thank you, listeners, for tuning in and being with us here at KCR, Kingston Community Radio on AM 920 and 92.5 FM WGHQ. And it's Monday, October 18th, and 45 degrees here in Uptown Kingston, and we'll be right back after these messages.
Warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters.
This fall, give us your best shot. Your photo of the Hudson Valley's autumn scenery could be worth $750. Enter Central Hudson's 9th annual Fall Foliage Contest today. If your photo gets the most likes on our Facebook page, you win. Deadline to enter is November 5th. For contest rules and information on how to submit your photo, go to Central Hudson's Facebook page or visit centralhudson.com.
Hi, this is Eleanor Arrow from the town of Ulster, and I support Kingston Community Radio, and so should you.
And thank you all for contributing and supporting Kingston Community Radio. And you're with us here at KCR, Kingston Community Radio, 920 on the AM dial, 92.5 FM, and streaming online at mykcr.org. It's 45 degrees right now on this Monday, October 18th. Let's see what else is happening with the weather for the next few days. Overcast with a 40% chance of rain showers today with a high near 55, only just up to 55. And tonight, partly cloudy skies with a low around 40. And Tuesday, mainly sunny with a high around 65. And Tuesday night, mostly clear skies, low of 52. So after today, it sounds like it's going to be a pretty nice beginning of the week. Wednesday, a few passing clouds, and otherwise generally sunny, and mostly clear sky Wednesday night with a low of 48. Let's get back to the on-air studio with Dr. Eric Stanberg and guests.
Here we go. All right, there we go. I am very excited. I have two wonderful guests this morning, very good friends of mine, and one thing I've learned as time goes on is how important our colleagues are, in any work environment. I think in medicine as well, very important. And I think that's something that, in this telemed, remote era, I think people are going to start missing more and more, whether they want to admit it or not. But I am accompanied in the room by two people that I get to have the honor and privilege of working with frequently over at Northern Dutchess Hospital. One is, who wants to go over? This is Laura Coriat and Cherry Chasson.
Morning.
Morning. They are nurse practitioners who work primarily exclusively over at Northern Dutchess Hospital with the hospitalist team. And they have graciously agreed to be guests on this morning show. I can't believe you guys get up this early.
Yeah, I didn't want to
day
get up
off.
this early. I'm on vacation, sort of, and didn't really want to get up too early.
No, it's fun. Yeah.
All right. So whenever I have a guest on, I usually just start about kind of interviewing you a little bit, let people tell a little bit of your story about the wind-up, how you wound up here. Dan? Dan's kind of an uptown guy.
Yeah.
Kind of an uptown guy.
You have a very nice voice.
I love that Billy Joel song. Billy Joel's writing a gender-neutral version of Uptown Girl, so.
We could start singing.
Yeah, but we have done that. I made Robin sing a couple times. All right, so Laura, tell me your story. How'd you wind up in Kingston?
In Kingston? Well, let's see. I've lived all over the country. I came to this area after I graduated from the University of Connecticut with a fine arts degree to work for my father at his bronze casting foundry in Rhinebeck, and then had a bunch of careers. I met my husband, and 9/11 happened, and I decided to go into medicine at that point. Previous to that, I was a sculptor and making medical models, and so I kind of worked on plastic things, not on real people. But I felt like I needed to help society, and so this is why I went into this career.
So 9/11 kind of inspired you to make a career change.
Absolutely, yeah. I didn't tell anybody about it. I was going to school, and I didn't tell anybody because I don't know why I didn't tell anyone. I
you
think they think I was
You were
crazy.
secretly? Were you with the class with a paper bag over your head? I mean,
Well,
somebody
I didn't
must have
tell
known
any
you
of
were
my
there.
friends that I was in school, and it was kind of weird, but that's what I did.
I don't know. It probably, people are kind of private about certain things. It was pre-Facebook, right? Nowadays, maybe you'd be all over social media.
I suppose, but I'm not on any social media whatsoever.
Aha! You've cut yourself off. What about you, Jerry? You also?
Not on social media either.
Yeah, I'm still on Facebook, but it's mostly as you guys know, with Robin and I, with the music stuff or stuff with
that
my
makes sense for you.
Totally.
yeah, stuff with my kids, and every now and then I'll post a reminder about Medical Mondays.
Yeah.
All right. So you became a nurse practitioner. Did you practice as so a lot of nurse practitioners are RNs.
Right.
Well, they're all RNs, but they maybe practice as RNs for at least for a while. Did you do that?
Right. I worked at Benedictine Hospital on 3 SMC for a couple years, and then got enrolled in school for my nurse practitioner. I worked at the Ulster County Jail for a county year. That's 11 months. And at Mid-Valley Cardiology. Then I worked in ICU in Kingston. And then I worked for Paul Pagnosi for 2 years.
Paul Pagnosi.
And then Kingston Hospital for 5. And then now I'm at Northern Dutchess for 5.
All right. Yeah. All right. And Cherry, what's your tale?
What's my story?
Yeah.
Well, as you know, I was born in Oklahoma. I was the first Oklahoman.
I was trying. What'd you say?
Was I the first Okie you ever met?
Yes.
Wait, were you born in Tulsa or somewhere? Or?
Oklahoma City. So in the center of the state. Yeah. Born and raised. Went to school at OU, University of Oklahoma, for nursing. So yes, I was a nurse for 4 years, I think.
Right.
ICU nurse.
Right.
And then went back to nurse practitioner school at Vanderbilt in Nashville. So moved to Nashville, Tennessee, where I met my husband and worked at Vanderbilt University as a nurse practitioner for 13 years.
Wow. Where'd you work there?
7 years in trauma. There's a level 1 trauma center.
Wow.
And then moved to medical ICU. Worked there for 3 or 4 years, and then to the ER for about 3 years. Yeah.
All right, so that's something I've never been exposed to. I mean, level 1 trauma, big city like Nashville. I mean, it must be really.
You're Cheese and Rhinebeck now.
Yeah,
right?
exactly. Yeah, very
little
twinkle.
different. A little different.
Yeah, but then my husband's from Montclair, New Jersey.
I didn't know that.
Yeah, and had been to Hudson Valley as a kid, different things like that. So we were looking to get out of the South and move up here. So kind of a reverse of what a lot of people do.
Reverse migration?
Yeah, what a lot of people do up here.
I don't know if many people are going to Nashville, per se. I mean, they're going to,
South Carolina, I've heard so many
Yeah.
stories. Yeah.
It's interesting, but I've had some friends and family actually go to places in North Carolina, South Carolina, and come back.
Yeah.
Saying that, it's cheaper down there, but there's just nothing there. They missed something about being in New York.
Yeah, it's a nice place to live.
Yeah.
But now I've been at Northern Dutchess for 5 years.
We started around the same time.
Yeah, we did. Yeah.
I've been doing shifts over there for 10 years. So it's really...
It's a great place to work.
It is. I agree. Yep. We have great colleagues.
Yeah.
You being one of them.
Oh, thank
our
you.
Our group is wonderful. And there's such camaraderie and teamwork, and it's really a great group.
And there are different personalities within that group. And I've talked a lot on the show over the years about the hospitalist movement and how it happened for a reason, but it kind of came with a price. A lot of doctors, patients still are kind of disappointed with me when they say,
not just you.
I know. Well, let me count the ways. But they're disappointed with me, because I'm not going to be there, when they're sick. So we did lose kind of continuity. We know that. So the substitute is kind of a well-functioning hospital team, and then good and hopefully improving communication with the physician on the outside.
Right. The flip side of that is sometimes patients ask me, "Do you have an office?"
Yeah.
Which,
Because they're unsatisfied.
Because they're disappointed with you.
That guy didn't come in to see me, but you were here. It's okay. It came with a price, so people kind of lost continuity. Their doctor. Actually, every now and then when I'm working, I see my own patients, and it is kind of patients really appreciate it.
Yeah, they really do appreciate that. Yeah.
Well, actually, I think that it's having worked on the nursing side, to have the physicians and nurse practitioners in the hospital makes it a lot easier for the nurses. We are there all the time. There's always someone there. It's easy to contact us, and we can be there in a second. But if a doctor is in the office and seeing patients, it's impossible to get.
Right, and that was one of the cases basically for the movement towards having hospitalist teams. Was the old days, we rounded in the morning and then made it, then probably didn't round until the following day. So if things changed or evolved, when you have a team of providers in the hospital itself, they can
Yeah, I just remember
evaluate.
Like when rapid response teams were first getting started, I would have to call the doctor in the primary care office and say, "Hey, your patient just XYZ. Well, I won't be there till after 5.
That's right.
So, yeah.
Continue chest compression.
Right. for 3 hours. So it just shows you how it's complicated.
Very.
I think we have a caller, believe it or not. All right. Good morning, caller.
Hi. Thanks for taking my call. So, doctor, I have a question. When you made the remark about the people currently in the hospital with COVID are unvaccinated, do you know the age and the BMI of those people on average?
Well, guys, you guys have been taking care of patients. What would you say is kind of our? I tell you what I seem to notice is that they're usually middle-aged people.
Yeah,
50-ish. Yeah.
And so you're quoting a middle-aged person as 50 and up, or?
40s to early 60s, I would call.
And what about the BMI issue?
I think people are generally a BMI maybe around 32 or something.
Yeah,
they're not
Male and
grossly
female.
overweight, but
Not
So
always
they're mildly obese. Is that a correct?
They do tend to have other health problems. There are exceptions, though. You guys have had some 30-year-olds that needed to be admitted, for example.
Right.
But
So then I have another question. Have either of the two, I'm going to go out on a limb and assume the two PAs have been vaccinated.
Nurse practitioners.
Have you received a mammogram since your vaccination?
Yes.
Yes.
Okay, and when you went to get your mammogram, because I went in the end of August, and the first thing the technician said to me was, "Have you been vaccinated?" And I said, she said, right after that, the only reason I'm asking the question is things tend to show on a mammogram if you've been recently vaccinated.
Right.
Well, you might get a little lymphadenopathy on that side where you got vaccinated, and that might show up in a mammogram, but probably very soon after, not like if you got vaccinated in February. That's probably why they asked you that.
But how do you know what the long-term effects of that there could be?
Well, the concern is that the mammogram will then kind of be abnormal, but it's really not abnormal.
It's not. It's just
So
temporary.
it would be a false positive, and then you
Right, and I'm a person who at one time 10 years ago went through all this, and I have a big issue getting mammograms to begin with in the sense of, radiation can cause cancer, so let's radiate your breast every year. So I just wanted that. And then the only other thing I wanted to say is when you make the statement about the FDA approving the boosters or approving these shots to begin with, I think people need to realize, the FDA still approves you can eat a Twinkie. That just because the FDA approves it doesn't necessarily mean it's safe.
Actually, I believe that's why they approved it.
It's true that it was, because of public health reasons, it was kind of a faster process. By the way, I believe ex-President Trump called it Operation Warp Speed.
Warp Speed.
But I look, I have faith in the FDA approval process for these vaccines. There's things I'm uncomfortable with, kind of like the revolving door of the FDA.
Absolutely.
People go from Pfizer to be the FDA director, and then they're back to working for Pfizer. I agree with kind of like this kind of an incestuous dynamic that can occur in the industry.
Right, and what about, if you start really reading food labels, you pick up a bag of Lifesavers, and it says produced with biogeneric engineering. Well, what is that? And that's approved.
Yeah, okay.
So I'm just saying that sometimes, I just wanted other listeners to just think. I think in this country, in my humble opinion, we've lost our ability to have a debate, and especially a debate over the COVID vaccine. And that's all I'm going to say. But thank you very much for allowing me the opportunity to voice my opinion.
I appreciate you listening, and I'm thankful that you called in.
Okay, thanks a lot.
Okay.
Bye-bye.
I do agree with her that rational discussion is something that needs to occur. So I appreciate her calling and offering her perspective,
Yeah,
Absolutely.
sure. Everyone's got an opinion.
Yeah. I have faith that the FDA has done I can't believe I'm using this phrase because I don't like it. Due diligence. Regarding the vaccine. I do.
I think so too.
Well, it's a very well-vetted vaccine.
Yeah.
Think of all the millions of people who have received it, and
But
you don't want to get COVID.
No.
It is recommend that you not get a mammogram so soon after the vaccine.
Right, and I think now that you just tell them, I just got this, and maybe
Yeah.
they'll reschedule it. Maybe they'll have it a little bit later.
Is it 3 months? I think it is.
I haven't heard that. No.
But so we were talking about the kind of the hospitalist movement and the plus the advantages. I kind of gave a little editorial about a disadvantage, which is people lost continuity. I think there's steps to improve that, communication. We still got a ways to go, but I think we're doing all right.
I think our hospital system is pretty good, though. We send out discharge summaries that explain what happened with the patient to their primary care provider. So we write good discharge summaries that have all the information in it, so they know what happened. And they're also informed when the patient comes into the hospital.
Right. In the office, we have a care manager. Care manager is kind of a new role for many offices. It's an RN, almost exclusively, a registered nurse, and they have different jobs, but one of which is to kind of help facilitate what they call the handoff from a hospitalized patient to an outpatient setting. So when someone is discharged from Northern Dutchess, for example, the care manager will kind of pick up the case, also, and then help segue a appropriate hospital follow-up.
Good.
That's great.
That's needed.
And when it works great.
Yeah, sounds good.
All right, so you've been doing this for about 5 years. So, what are your thoughts? So, what do you think is evolving in the world of hospital medicine? Are you seeing more of something, less of something, something that's challenging?
The ER has gotten a lot busier recently. I know that. People have delayed care, going to their doctors because of the COVID pandemic. So we see people coming in sicker sometimes or with some chronic illnesses that are out of control. That's one thing that's been difficult.
I know that the offices have been...
Primary care is just so busy.
Right.
That if they can't get in a reasonable time with their primary care provider, they have no choice but to show up to urgent care, ER, that kind of thing. Which I can't fault them for that at all.
No, in a way, that's, urgent care, exists to kind of, handle acute problems that the primary care office can't handle.
Yeah.
For because if it's off hours or because they
don't get a call back in time. Things like that. I know you those problems.
I know those problems.
Yeah. It's tough. Healthcare's tough.
I don't fault someone for going to urgent care if they're sick. That's why it's there.
Right.
Sometimes though, they're like, we give them an appointment, and maybe at 3 p.m. and then the appointment kind of comes and goes, and when we reach out to the patient and say, well, what happened? They said, I decided to go to urgent care.
Right.
So,
Well, you get 15 minutes of free time. Good for you.
well,
Not really.
What's that, Dan?
It just weaves into the next task,
Kinda.
which you might be a little late for anyway. So.
Well, sometimes I call it the strategically placed no-show. When you're really kind of running like 15 to half hour behind, and all of a sudden someone doesn't make their appointment, and that helps you reset. That's right.
Yeah.
You worked in the office with nephrology, Dr. Pegnosi?
Yeah, with Grand Street Medical when they were. I guess they're not called Grand Street Medical anymore.
I'm not sure what they're called.
Westchester Medical Center.
I guess so.
I don't know.
Of Kingston.
Yeah, of Kingston.
And just to give a little mention of our colleague who's passed away, Dr. Paul Pagnosi. He was actually the host of this show prior.
I didn't know that.
Taking us over.
Oh, that's right. Yeah, he never invited me to come on.
He would have like 5 or 6 people on. I don't know. He was very much more persuasive in getting people on, I guess.
Yeah, at that time there were at least 3 doctors that were co-hosts, including Dr. Froud.
Dr.
He was a co-host as well. And I remember you coming in as a guest with them.
Yeah,
At
that
least a
was,
few
and
times.
the doctor I won't mention, but he went on a political rant on the show. We talk about politics, but politics related to healthcare, and then I try not to really offer too much of my own opinion.
Yes, I'll be quiet.
Well, you're allowed to have an opinion. By the way, you're a guest.
Have an opinion.
That's right.
You're a guest. You can have an opinion.
Oh, okay.
And I have. Then we'll tell you. Every now and then I do share my opinion. Wait, when this is a aside, but I really the coverage for Suboxone has ridiculously gotten harder for people. MVP. Oops. Did I say MVP? I did not mean to say MVP. I'm sorry I said MVP.
I already beeped it out.
What'd you say then?
I said I already beeped it out.
Okay. If I say MVP again.
What was it? MVP?
Yeah,
you said?
but if I say MVP again, but they something went wrong with their authorization process, and instead of authorizing 60 tablets, the limit is 6 tablets, and then it has to rather than fix the problem, they now require a guy like me to get an override, basically.
Oh gosh.
It's just but then our own Medicaid system. So this is not a private insurance company. Also, kind of waivers between insisting people have the brand Suboxone versus the generic, and then then they flip back, and then it just results in prescriptions that get delayed, and just not good. I'm not quite sure what's going on here. Frustrating. Anyway, that's a little side. Sorry. So, what do you guys? You think people are sicker when you guys admit them?
Yes, definitely. Yeah.
But
To get
we're-
admitted, you have to be sicker. You just don't get admitted into the hospital if you don't meet certain levels, and it's unfortunate sometimes. People we have to send back home, and people have to deal with certain illnesses at home that they just never have had to before.
Right. Well, there are things that we don't admit anymore, right?
Right,
Remember
right.
DVTs?
DVTs, yeah.
A clot in the leg is called a DVT, and that is now
cellulitis just doesn't get admitted.
certain types of infections. Even pneumonias won't necessarily get admitted. We talked last week about a case where the man was seen at an ER, given the right antibiotic, discharged, and then readmitted. He wound up having Legionella. We talked about that last week. And he was a little kind of upset that he got sent home to begin with, and it's just very important that that we kind of say, hey, it was the right decision. You just you didn't get better. You got and he did fine, by the way. But sometimes patients walk away with the impression that something was done wrong when really nothing was done wrong.
Maybe failed outpatient treatment.
Right. Maybe we should stop using failed. Maybe that's, the semantics are important.
Sometimes you just need IV antibiotics.
Right.
Sometimes those work much better. This is why you're in the hospital.
What about the effect of not just elderly patients, but the super elderly, right?
Oh, yeah.
In their 90s.
103.
You had 100.
103-year-old a couple of weeks ago. Yeah.
Yeah, that was impressive.
Mm-hmm.
Were you working that day?
I know. I think remember seeing her on the list.
Yeah.
You want to, without divulging personal details, what was the reason she was in the hospital?
She's 103, and her body was just failing. I mean, up until that point, she'd been with her family, home, doing okay.
Came in and passed away?
No.
No, she had chest pain, right?
It was I think more like confusion, hallucinations. I mean, you're 103, so yeah.
I'm sure you guys are get frustrated by the lack of preparation on the part of patients and families when someone is seriously ill. In other words, the talk.
Advanced directives.
Right.
Right.
Living wills, advanced directives, healthcare proxies. These are all terms that kind of get thrown around. I try in the office. Cherry worked with me in the office for several months.
Try. You have a limited amount of time.
I have only so much time, and then there's kind of a resistance from the patient.
Yeah.
I was talking to one of the residents about this yesterday. I thought when someone is very sick, they code, right? A code is kind of like what you see on television, ER.
You're clinically dead.
Basically, you're dead or dying when you're coding. And it's and the process of running a code is kind of upsetting, right?
Absolutely.
It's a room full of people. You're kind of nude. And people are doing things to you. They're trying to draw blood. They're trying to maybe put a tube down your throat. They're pressing on your chest. They're giving you electricity.
Breaking your ribs.
The survival rate of a code is actually rather low.
Very low.
What is it? What number are you guessing?
Like 3% or something, is it? Maybe it's higher than that.
Higher than that, but
outside it's very low, but inside the hospital.
I would say about 90% unsuccessful. But
ultimately, to be discharged out of the hospital, it's usually very low. I mean, even if you intubate somebody and resuscitate them, get them return of spontaneous circulation, you just usually don't make it out of the hospital after something like that.
Right. And even if someone is revived, they're usually quite ill. Anyway, so why are we discussing this? Because it's relevant for what you have to do every day, right? Because people can be quite ill. And
if they're the elderly, meaning, 80 and older.
Yeah.
Oh, good. I'm not elderly.
No, you are not.
Pretty soon.
I think a lot of times people appreciate us sitting down and talking with them about, advanced directives. They usually have a healthcare proxy in place. Sometimes not, or they at least have someone in mind. But to talk about, if they would want CPR, then actually explaining to them what it is. A lot of times people have seen it on TV.
Right.
And they can relate in that way. A lot of times, they've had family members that have been on a ventilator or have had to have CPR, and so that they can relate to that. Usually if someone's been on a ventilator before, they don't want to be back on it, has been my experience. So when I tell them, have you ever been on a ventilator? Have you ever seen anyone on a ventilator? They usually say, yes, and I don't want that. So that's helpful.
One of the roles of our care manager in the office is also to help with this discussion, the talk, because it takes time.
Absolutely, yeah.
And every now and then I'm surprised. I'll have a patient who's maybe 90 who just, in their own words, wants everything done, and then I'll have a patient who's like 70 and rather healthy who kind of says, absolutely not. When it happens, it happens. So it's very unpredictable.
It is.
I think COVID definitely made us visit advanced directives a lot more than we were, even though it's something that's on all of our minds all the time. But, chances of being ventilated on COVID were high initially. So so we definitely had that discussion, and I had a couple young patients who did not want to be intubated. Young, I say 60, in their 40s, who didn't want to be ventilated, who had COVID, and they just didn't want that experience, even though the other choice would be to die.
Well, I do try to share vignettes on the show, but of course there's confidentiality issues, and we live in a small town. And, but okay, we have 1 minute to our break. But a patient passed away from COVID-related causes at the hospital on, I think, Thursday night. It was actually my patient in the office too, and she, didn't want to be put on a ventilator. So it was very, very sad, to be honest with you. You know,
Yeah.
relatively young, 63, young.
Oh, wow. Mm-hmm.
Like that.
And, you know, did not get vaccinated, and, you know,
Yeah.
and she passed away from it, so it's sad.
Oh, I'm sorry to hear
Sad.
that.
You know, when this happens where someone is kind of diagnosed with COVID, I mean, I don't go into lecture mode,
No,
you know.
it's not the time or place.
Yeah, it's not the time or place. I like to think that they'll emerge from their experience.
I've had a lot of patients emerge and say, I'm going to go, you know, be an evangelist for the vaccine.
Yeah,
So-
yeah, I don't want to go through this again. I don't want
Right,
anyone else to
right.
go through this.
Yeah,
I've had a few who
I
still
applaud
kind of
that.
say,
Well, you
Yeah,
know,
definitely.
your choice.
all right, we're going to go to our break, and then we'll continue our discussion afterwards.
Thank you, Dr. Eric Stanberg, and a very, very special thanks to Laurie Coryett and Terry Chasen. And it's 8 o'clock. You're with Dr. Eric Stanberg with Medical Mondays. This Monday, October 18th, 45 degrees here in Uptown Kingston. And this last portion of Kingston Community Radio was brought to you by Central Hudson. And we'll go to the on to our breaks right now.
As warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters.
This fall, give us your best shot. Your photo of the Hudson Valley's autumn scenery could be worth $750. Enter Central Hudson's 9th annual Fall Foliage Contest today. If your photo gets the most likes on our Facebook page, you win. Deadline to enter is November 5th. For contest rules and information on how to submit your photo, go to Central Hudson's Facebook page or visit centralhudson.com.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you, and support KCR.
And you're listening to WGHQ AM 920 and 92.5 FM, and streaming online at mykcr.org. A little bit about the weather and forecast for Kingston and the surrounding areas. By the way, this last portion of Kingston Community Radio was brought to you by Central Hudson. Today, a little bit of rain, overcast with a 40% chance of rain showers today with a high near 55. And Monday night, tonight, low around 40 degrees. And mainly sunny tomorrow, Tuesday, with a high around 65. And Tuesday night, mostly clear skies, low of 52. And Wednesday, pretty similar, a few passing clouds, otherwise generally sunny, and a high of 74. We're getting back up there with a little warmer temperatures in the next couple days, Wednesday and Thursday, and a mostly clear sky, a low of 48 for Wednesday night. And this upcoming portion of Kingston Community Radio is brought to you by Herzog's. Do you ever think about what really matters? At Herzog's Home and Paint Center, community, family, and neighborhood all matter. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. And visit Herzogs.com. They always have ongoing sales. Monday, October 18th, 45 degrees right now. Your call-in number is 331-9255. Thank you, callers, for calling in so far today. And let's get back to the on-air studio for all of our next festivities, including the Boyce Dairy Milk House birthdays.
All right, good morning. Welcome to the second half of this morning's show. I'm here in the studio with two friends of mine and two wonderful people and nurse practitioner who work over at the hospital with the hospice program, Laura Coryett and Terry Chasen. Did I say it right?
You did.
Okay. Now, this is when we get to do birthdays. This is actually not only the high point of the morning, but the high point of my week.
Oh, nice. It's birthday.
So
cowbell.
and I do a little Christopher Walken imitation And should I do the Christopher Walken?
Yeah, do it.
All right, well, not yet. All right, so we have a birthday today. So the winner is going to win a famous cow pie, courtesy of Boyce Dairy Milk House, 62 O'Neill Street. I could do this. I feel like I'm doing, with Garrison Keillor when I do this stuff. Boyce Dairy Milk House, 62 O'Neill Street, Kingston, New York. A famous cow pie, and we have one person. So this is today's winner. Happy birthday to Robbie Andreasen from your friends, the Meyer family. Have a great day. So go ahead.
What exactly is a cow pie? I know what a cow pie is in slang terms.
It's a delicious, yes, right. Well, it's not even a slang term. It's actually what it is on the field. But
right, it's a little,
Boyce Dairy has a huge, beautiful farm outlying Kingston, and they have a dairy processing plant right on O'Neill Street. And the Boyce Dairy Milk House is a great store for all the Boyce products, including soft ice cream and everything. And this is a frozen soft ice cream pie.
Sounds delicious.
Frozen soft is a little bit of an oxymoron.
It is, but it comes frozen. It's made with soft ice cream, but then it comes frozen.
Right.
And you get to throw on all kinds of like little goodies on it too.
I guess you have partaked in one of these cow
I have
pies.
had one, absolutely.
They're quite good, actually.
Oh, okay.
Yes, so that was the cow pie and the cowbell. And, well, can you please give me the cowbells back?
Oh.
Let me go back in the...
Okay.
Should I do my Christopher Walken? I need more cowbell. It's not a bad imitation, huh? That's pretty good, right?
No.
Boy, what a funny bit that was.
It's a very
All right.
Watch that again.
So we're talking about just general hospital issues. We were talking about the importance of having a plan when people get very sick. I say to my patients, because I'm trying to work with them here, I say, Saturday at 3 a.m. in the emergency room is the wrong time to have this discussion.
Yeah.
But people just, I don't know. I don't have enough time really to do it justice. But I was saying that the care manager, Tom, is our new care manager, and that's one of his things he's going to help us with. Is also be able to talk to people about that. But your experience is that generally people are receptive to the discussion?
Yes. And also, when I first started years ago, the forms that you had to fill out for advance directives were very complicated. If you choose A, then go to section 5, and it was just very confusing. But now we have the new pink forms, medical orders for life-sustaining treatments that are very comprehensive and very easy to fill out. And they're going electronic. I don't know if you know that.
Okay. I just... I guess I'm old enough to get nervous when I hear stuff like that because we were having the conversation mostly with elderly people, and
well, we do it electronically, so it's in their record, so people can see it easier. But
still get a copy.
Yeah,
is it still pink?
I don't know. Actually, I'm learning about this right now, so I'll find out more and I'll let you know.
Because that's one of the points of the MOLST form. It's a shocking pink. Can't miss it. Our colleague, Dr. Liz Levine, who is now the director of the hospitalist program, it's one of her projects. She's working with some of the residents on that. So one of these days, her publicist will allow her to come on to the show.
We should have had her on this morning. Come on over, Liz.
She was just, where's she? She's next door?
She lives right close here.
She'll bring her dog. I don't know if that's allowed.
Sure.
So Robin makes fun of me too because I say it a lot. If we ever make T-shirts for the show, it's gonna be it's a big topic. That's the phrase, because it is the big topic. Medical Mondays, it's a big topic. But thinking about the future and again, I guess it's uncomfortable for most people. They don't want to think about it.
Superstitions. So a lot of people don't. They think about it. They talk about it. It might happen. They don't really want to.
Well, again, my almost cynical idea was to actually kind of film a code, put kind of obviously something to protect the identity of the individual and let kind of people see what it's like. It's not. It's pretty rough.
It's terribly rough. I mean,
you must have seen your share over at Vanderbilt.
It's rough. That's why, I mean, there was a movement, I don't know so much now, but there of like having families stay in the room. You know, used to we would usher them out.
Right.
To the waiting room, to the family room, and you know, then do the code. But now it's just let them stay there and actually see it, because a lot of times
they'll stop it.
They will say that's enough.
That's enough. Interesting. Interesting. Yeah. All right. So that's one message of this morning's show, is for people to think about this and
don't lay it on your family to decide for you.
Right.
That is very unfair to your family. Yeah.
And people are always a little confused about the living will and the healthcare proxy, and they're frequently on the same form, so no wonder they're confused. But a living will is basically your wishes.
Right.
And then the healthcare proxy is the assigning of someone to implement your wishes.
Yes.
So how often have we seen that, where all of a sudden the proxy kind of is, put in a very, panicky type situation and wants to kind of basically rescind the wishes of their loved one?
I haven't seen that in a long time.
As bad as it used to be?
Yeah, maybe at Kingston Hospital a couple times, but really not in a long time. I did my living will at age 29 because of the Terry Schiavo case.
Terry Schiavo.
And I never wanted to end up like that.
Schiavo, right?
Terry Schiavo, yeah.
Schiavo? Anyway, she was in a bad way. Very bad way.
Yeah.
It was bad, right? I remember, and that got very political.
Yes,
so political.
Yeah.
So that was, unfortunate. Well, I hate to admit it, but I don't think mine's done. So
mine's not done.
Well, you know.
I have people who, who would know.
Yes.
Yeah.
the most form itself is a 4-page document. I guess the back, but it's kind of I got a part 1 and a part 2.
Really just 2 pages, very, simple, yeah. First page, most important.
Part 2 can be a little confusing and not unusual for us to kind of have a patient come over from one of the nursing homes, and there's the form, and part 1's nice and completed, and we turn it over, and page 2 is blank.
Right.
I call the page 2 the what now.
What now?
What
right.
now? You
talk about this too.
Yeah.
Yeah.
The page 2 is really more of like long-term feeding. What if you are on a ventilator? Long-term. So the what now is important.
And exclusions, like if you don't ever want to be on dialysis, you could put that on there.
Right.
But the one thing that's really important about this form is it's dynamic and can be changed all the time. The 3rd page is a form where you fill out that you have discussed this again with the patient when they come into the hospital, and you put the date and if there are any changes. But
They're changed. I think you're supposed to do a new form, which yes. I think is a little.
Yeah, so I don't know why they have all those spaces, because you're just going to throw it out anyway.
You're just going to throw it out and start.
Patients bring it in like during their wellness visit with me. I'll review it and sign it. But I don't. There's some weirdness in the form. For example, it asks for witnesses, which is understandable, but doesn't ask for the witness's signature. Just asks for their names.
That's very strange too. Yeah.
Maybe so you could really pin them down, because you can read a signature.
Yeah. Oh, someone just, all right, we'll leave it at that. But so there's probably some improvements that could be made. But,
absolutely.
It's just important for people to understand that.
Yes. I
think the state insists on 2 categories. One is people in a nursing home, and people who are in their last year of life. But as we understand, that's a little restrictive, isn't it?
Oh, yeah.
But though I guess if we just focus on those 2 groups, we'll kind of miss people.
Definitely.
All right, so the hospital dynamic. So we talked about, we were talking about like not just the elderly, but the super elderly, like, people in their 90s. And then you were talking about a 103-year-old who went and had a procedure done, So it just shows you how it's individualized.
Oh, very, very individualized.
I remember I had a patient, and she's since passed away, but she's in her 90s, and she had a bad aortic valve and needed to basically have a procedure, but really just didn't want it. This was a patient who really was, I don't want anything done. I'm ready, whatever happens. I'm going to let it happen. But she clearly was not doing well, having fainting spells. And it was, with her sons, eventually she had the procedure, and she did okay for, for a year or 2, and then she, did pass away. But it was a good example of how it is case by case, and it's hard to kind of have a hard stop. I guess it's our job to kind of look at the patient individually.
Mm-hmm. Right, of course.
Yeah, always.
So what do you think about the effects of kind of like technology on what you do? I mean, right? We all work in our charting. I call it the charting room. You guys have another name for the room?
Charting room.
Okay. But we're at computers a lot, right? And then
we are too much.
Reports of residents kind of spending most of the day on computers. How do you deal with that? How do you kind of make sure that you still kind of keep the personal connection with the patients?
I try not to be on the computer when I'm in the room with the patient, because I think every study that's ever been looked at that has said patients hate that, and I kind of hate it too. I'd rather just be listening and focusing on them. But a lot of times if they want me to change orders, or they are not on the right medication, then it's just easier as I'm talking with them.
Or they start asking for we want to review labs.
Yes,
and
all
of a sudden you
or they want to look at a CT scan or a chest X-ray. Then that's when it comes in handy. Is like you have it right there, you can wheel it right there, and they can look at it and understand it and ask questions about it in real time.
Right.
That's when it's helpful, but I just, to sit down and do my notes all in one fell swoop, I can't do that. I have to get up and move around.
Right.
I think it's really great, the EMR, particularly the one that we have at Northern Dutchess Hospital. I can see your patient from your office in the hospital and see your last note, review the medication changes, and I can also look at the patient's pharmacy records from outside, and I think it's great. And we dictate our, well, it doesn't work all that great all the time. Dictate our notes so it's easier. We don't have to type a lot, and
you have to proofread it though.
Oh yeah, I've written some really funny things, but that I've missed. But I catch them the next day usually.
Yeah, it happens in the office too, where I'll review my note. I'm like, just a little, the equivalent of typos, basically.
Mm-hmm. But there's some providers that have some really funny.
Yeah, a little
dictations that maybe don't
stream of consciousness poetry.
Yeah, it's really kind of amusing. I guess.
All right, so you see advantages and pluses
absolutely.
in it. Okay, well that's
And having worked with a bad EMR before, this one is really nice. I like
interesting. Because we always tend to have kind of like rose-colored glasses about about everything.
But I remember in the days as a nurse having to read doctor's orders, and that was very difficult sometimes.
No, absolutely.
It's like who could have the worst handwriting, and it was.
And when I'm complaining about the EMR in the office, which happens occasionally, all the time, I try to remember what paper charts were like. They
writing notes, progress notes, soap notes.
They got lost. They were unorganized. When the patient got thick enough, it literally just fell apart. And things were buried in the chart.
Mm-hmm. Mm-hmm. And you'd have to get the chart from the records, the previous chart sent up. And then when you try to do a discharge summary on written progress notes, and you're trying to I used to have to write a whole map of what happened and chronology, and it was crazy.
A little detective work.
Yeah, it was hard. It would take an hour and a half.
There are things though I kind of missed, the kind of just turning the page, because in the computer you have to open it, close it, open it, when you're trying to read, how something happened. But I joke with. And it's just a joke with my nurse. I say the worst thing about the EMR is I don't have charts to throw anymore. Right? You had we both worked as nurses. I'm sure you had the doctors throw the charts.
Go to anger management for that.
Yeah, I'm enrolled for the whole semester.
You can throw your cell phone now.
I've done that. The screen is broken. I swear it was an accident. The case broke, and so now it didn't have a case. So when it did fall, of course my kids are like, "How come you didn't get a new case, Dad?"
That's right. Maybe for your birthday or something.
My kids like to say to me, "Okay, boomer."
Boomer.
I usually say I'm not a boomer, but I'm close. Depends how you define it.
what is a boomer exactly?
Well,
What age? I'm probably a boomer.
There's definitions kind of vary, but I anyone born between 45 and maybe as
60.
late as 65.
65.
Okay.
Yeah.
Well, like my brother, for example. I think you are, and you're not. And I'm kind of in the middle. But my brother was born in 63, and I was born in early 66. So I don't consider, and our parents were not World War II people. My father was, you know what I mean? That's also kind of
That's
one of the
true.
dynamics of the boomer generations. The parents were kind of either
we'll
veterans.
allow
or,
you to be a boomer because you're close. You can be a boomer.
when you think
invited
about
in.
you think about my tastes in music and things like
you're a
that,
boomer.
and probably some of my thought processes. I think it's probably close, yeah. But that phrase "okay, boomer" is kind of a funny one, and it really upsets some boomers.
Some people, yeah.
But it started with a woman, I think, from New Zealand, a young woman who's in charge of New Zealand, like 35-year-old.
Oh, yeah.
And she, I don't know, was getting a hard time from somebody, and she said, "Okay, boomer," and they got really upset. Anyway.
Ageism,
yes.
darn it.
Well, that is something that does concern me, though. I mean, as we get older, the technology is going to continue to evolve, and my ability to kind of evolve with it might be less. It might become more difficult. When I was in medical school, the older doctors were lions.
Mm-hmm.
They knew everything, and they've been doing it forever. And they were doing, primary care docs were doing things that younger primary care docs wouldn't even go near.
Mm-hmm.
And now with the EMR, they're kind of in front of a computer, really kind of struggling. I think like almost like a Don Quixote, trying to fight a windmill. This kind of dinosaur from another time.
But they can also look everything up. I mean, I find it very handy to be able to go into Epocrates and look up every medication and have up-to-date at my fingertips so I can look up different disease processes, and it's pretty handy.
Right. And you talked about, trying to make sure you're not buried in the computer while you're interacting with the patient. It's not unusual. If I have a consultant that I send the patient to, and then when I see the patient back, I kind of try to get a little bit of a report. How did visit go? Because I want to know from the patient's perspective. But remember, I also refer patients, so I want to know, how it went. And then sometimes they feel like the provider was buried too much in the computer, and that makes me sad. I don't think it's the provider's fault.
Yeah.
My father had to go for a visit, and it was such an awkward visit with a vascular surgeon, and it was set up on the wall, and then the specialist literally had to turn and have his back to us. Mm-hmm. So some of it was really just the way it was set up. It was just so awkward.
Mm-hmm. Yeah.
So I do bring the laptop in, but I try to kind of position it just analogous to having the chart.
I remember you would face the patient and you'd have the computer right there, because a lot of times you are looking up things. You are looking at previous an echo or something from.
And when I'm ordering labs, for example, particularly the Medicare patient, I'm always very forthcoming. I say, what I'm doing now is I'm making sure everything's coded correctly, because if it's not coded correctly, you're going to get a bill.
Yeah, exactly.
Then they'll let you take all the time you want.
Yeah.
I sort of understand that this is what it is.
Billing,
I can't just order, a CBC. I have to attach it to a reason that I'm ordering it. And if Medicare doesn't agree with the reason, it's not going to be covered, and the patient might get a bill, and that's upsetting.
Absolutely.
Do you find that people are worried about the cost of their hospital stay sometimes?
Yes, particularly observation patients when they come in. They say, because I think when Medicare started requiring observation versus inpatient, there was a situation, where some patient was in the hospital for an extended period of time and they never changed the patient's status to inpatient, and then they got this crazy bill.
Yeah, what's your take on that? The observation,
I think that's pretty standard for like the case you were talking about earlier, like a chest pain rule out MI. I mean, that's pretty standard. Stroke patients, if it's not actually documented that they had a stroke when they first hit the door, then they stay overnight, and they usually get an MRI the next morning. That's usually an OPS. A lot of these social admissions, we call them.
We used to,
we used to call them that, but
by the way, you have to do them.
Yeah, you do. But a lot of times it will only
or something like
weakness.
that.
We can't really explain it. They don't have a UTI. They don't have dehydration. All their labs look spectacular, but yet they can't walk. What do you do?
What are you going to do? I was talking about a case probably about 20 years ago at this point, but it was someone that the police just kind of didn't know what to do with an individual and brought him to the hospital. And I think I was on service at Benedictine, and I got called to admit him. And so this kind of confusion and the merging of the social and the medical, and kind of expecting the medical system to assume social roles and then have a payment system that doesn't allow for that at the same time. So there's obviously a disconnect there.
Yeah, definitely.
Yeah.
A
Sometimes
lot of
you
people
need a social worker, but we don't have social workers overnight. We
Right.
have them like 9 to 5, and Monday through Friday.
But if someone has no place to go,
No place to go. Then
home. You have anybody ever worry about their deductible? I do. I see it in the outpatient setting, and
I think I had a patient recently that was in the hospital that was on expensive inhalers. They're all expensive, and on a anticoagulant that was expensive, and she was in the donut hole.
the donut hole. That's time of year, the donut hole.
All right, so
Pretty severe for this
I'm not very well versed with Medicare, but I'm getting to the age where I'm starting to look at the articles about it, which is, I don't know, it looks very confusing to me. But, it was so expensive for her to be on these medications and, had to switch them around a little bit.
I don't even understand the donut hole. I mean, basically, usually for 10 to 11 months of the year, the meds are covered, and then you reach a limit, you have to pay a little bit, and then it kicks in again.
Sometimes it's like a life or the annual limit of like $5,000, and if they're on 12, 13 different medications and they're expensive, like inhalers or anticoagulation, a lot of it's safer, but it's more expensive. Then they miss. Come around October, they don't have any more medication because they can't afford it.
Yeah, I talk a lot about it in the
horrible.
outpatient.
It's just horrible.
Yeah, the outpatient setting, the world of diabetes, for example, has exploded, and they're great medicines. These SGLTs and the GLPs and all this alphabet soup of these meds, but these are great meds, but it can be quite expensive for people.
Yes.
And it's very frustrating in the outpatient setting. I've also talked about, the quality, kind of being measured by the A1Cs. And here I am trying my best to help this person get a better handle on diabetes. And next thing you know they can't afford their medicine. And,
right.
So that can be very frustrating.
Absolutely. Yeah.
What, you want to say somewhere?
I was just going to say that I think medications for diabetes should be free.
Well, we could. That's a big topic. I mean, because we've all kind of been there. People who are uninsured or underinsured. The whole idea of a high deductible plan, that was kind of an idea that somehow, if people had more skin in the game, they wouldn't run to the ER, run to the hospital.
It's
I don't know
not
if
true.
that works.
It's not doesn't work. No.
Yeah. No, people. It hurts. It's hard in primary care because people don't want to come in for a visit. I feel fine. Why do I have to come in and have you check my blood pressure, for example?
I think in the hospital, people may have that discussion before they get to the hospital as far as deductible, but once they get to the ER, and then if me and Laura go down and see them, then they're getting admitted. So I've never had anybody talk to me about a deductible.
Yeah, it's interesting. I mean, and maybe they're not thinking about it at that time.
Yeah, yeah.
And it's interesting because a lot of people, when people talk to me about their insurance plan, every now and then I'll have someone say, I like my insurance plan. And the story is sometimes something happened. They needed a stent, for example, and the insurance paid almost everything.
Yeah.
So they're kind of happy.
I mean, if anything, in my past life, I had tons of patients that weren't insured at all. And that was always a big deal. I don't want to stay in the hospital longer because I don't have medical insurance.
Where was that, in Nashville?
Yeah.
I wonder if there's any...
They didn't have expanded Medicaid. We didn't expand Medicaid.
I think.
Yeah, Medicaid, yeah. So a lot of trauma patients are younger and they don't have health insurance. And, we dealt with that all the time. Up here, it's much less of an issue. Yeah.
Trauma in general is from a business point of view is a tough subject for hospitals because you're right. A lot of people don't have insurance. In our state, it's covered through no fault most of the time, but that's difficult.
Sure.
So it's sad in a way because in a way that's those people really have no choice. I don't understand some of this kind of like price transparency, that somehow if patients knew how much something cost,
right.
they would go to a different
Shop
hospital.
around.
Yeah. You know, I'm having chest pain. Now, you're too expensive. I'm going to sign out and go to the other hospital. I just trying to figure that out.
I don't understand that either.
No.
Because, I mean, what if it's just going to end up somehow being on the patient where they're going to, maybe they didn't make the right choice and the insurance company's going to get mad at them. Sorry, Brian, about insurance. But if you're listening, I don't want to.
Sorry about what?
I don't want to say anything bad about insurance.
Well, just don't mention a company like I did.
No. What, MVP?
Again, over and over. Oh, we're talking about baseball when we say MVP, by the way.
Right.
So, who's going to be the MVP? All right, we're going to go to a break, and then we'll come back.
Okay.
Thank you, folks. Thank you so much. And thank you, Dr. Eric Stanberg, and a very special thanks to Laurie Corriette and Terry Chazin. And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. The time is now 8:30 a.m., and you're at the bottom of the hour right now with us, 7 to 9 a.m. every weekday. Monday, October 18th, today, and it's 46 degrees here in Uptown Kingston. Because the color and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. Color decorating consultants and expert interior designers are ready to assist you in choosing the right colors. Visit Herzog's in the Kingston Plaza. We'll be right back after these messages.
Everyone is talking about healthcare these days. America spends twice that of other developed countries on our healthcare system, yet our health ranks near the bottom. How can we stop spending so much and getting so little? Shifting to a system based on primary care can help fix the problem. Patients with a primary care doctor live longer, healthier lives and are less likely to suffer from cancer, heart disease, or stroke. Primary care that is comprehensive and coordinated also saves money. Patients who have a primary care doctor spend 30% less on health care than patients who don't. States with a high number of primary care doctors have lower health care costs and higher quality care. Primary care can help make America healthy again. To learn more about the benefits of primary care, visit www.healthisprimary.org. This message is brought to you by America's Family Physicians.
Millions of conversations will happen today, but few of us have had a conversation about the care we want when we're seriously ill or nearing the end of life. Sharing your wishes with friends, family, and care providers now and as life changes may improve quality of life at the end of life, both for you and those you love. This conversation may be difficult, but wouldn't you rather have it now, before a crisis? It's time to have the conversation. Visit iom.edu/theconversation. A message from the Institute of Medicine.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio, so please keep listening and supporting our station.
And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. 46 degrees on this Monday, October 18th, and a little bit about the weather and forecast for the next 3 days. Overcast with rain showers at times today, good 40% chance of that. And tonight, partly cloudy skies with a low around 40. Tuesday, mainly sunny, a high around 65. And Tuesday night, mostly clear skies with a low of 52. And Wednesday, a few passing clouds, but otherwise generally sunny as well on Wednesday with a high of 74. And Wednesday night, mostly clear sky, low of 48. And let's get back to the on-air studio with Dr. Eric Stanberg and our guests one more time. One more half hour.
All right, Dan, thank you. Welcome to the last half hour of this morning's show. We have two guests this morning. Terry Chazin and Laura Corriette. They are nurse practitioners that work with the hospitalist program over at Northern Dutchess. They are my friends and colleagues, and I'm thrilled that they are here. I really look forward to working at the hospital. Right, my Robin is always like, dude.
What?
Why? When are you going to work in the hospital full time? Because you really enjoy it more. And I just, I don't know. I have a lot of patience, and I just, I don't want to.
We could give you a lot of patience in the hospital too. That's not a problem.
Just don't do urgent care. Just do.
I urgent care. I'm not doing it right now.
You're not?
No, I have a couple shifts scheduled for October, but I'm getting the opportunity to do some work with the outpatient family practice residency. On Tuesdays over. So I've done that twice. I'm doing it again tomorrow. So I'm looking forward to that. I think
at that.
I think the resident physicians over at Northern Dutchess are fabulous young doctors.
Yeah, they're a lot of fun too.
Yep.
I say it's not the doctors of tomorrow I'm worried about. It's the healthcare system of tomorrow that I'm worried about.
Absolutely.
Yeah.
The one that they're going to have to function in. Or you were telling us during the break that you started to work for hospice?
Yes, I'm working per diem for hospice now. I started 2 weeks ago. And it's a fabulous organization. And today I'm seeing my first patients. So I'll be doing that this afternoon with another nurse practitioner.
Interesting.
So are they, you mean like Ulster County Hospice?
Ulster and Dutchess, yes.
Is it the same?
I should know, Hudson Valley Hospice. Let me get their name right. Basically, the nurse practitioners recertify people. So they've already been certified. After 3 months, they have to be recertified. So you go to their house. I thought it was 6.
No, it's changed? Or?
I think it's 3 months. I'm learning a lot.
Okay. You just started.
I just started.
That's great. So was there a particular reason that you wanted to work with hospice?
Yes, my mother died in March, and she was on hospice, and I was so impressed by them, and I just felt like I needed to do something more meaningful for me, and that's the only reason I'm doing it. Well, for the patients as well, but because I need something more fulfilling in medicine, so I think this will be it.
Okay.
And the organization is great. The people I've met there are all so nice and supportive, and they're growing in leaps and bounds. They have over 500 patients.
That's what I've heard.
So it's basically the same organization, Ulster County and Dutchess County?
Yes. Yeah, they have an office here in Kingston and Aaron Court, and then in Poughkeepsie on Violet Avenue, just in northern Poughkeepsie. I guess it's northern. You should look at the map.
Do you feel that people, if they're candidates for hospice, do you feel that they kind of utilize it at the right time?
Probably not all the time. I mean, we see that in the hospital where people, I think hospice, people have always thought, well, if I go on hospice, it means I'm dying now. It's like when my mother came home on hospice, my sister said to her, "You're coming home to die," and it was just the wrong message. But I don't want that kind of attitude for sure. But the hospice offers a lot of great services to the families and to the patients.
It's just an added layer of support for the patient and the family at home. Not so much in the hospital. I mean, they do visit while patients are in the hospital, and then you have respite. You have a week of respite. It's just another layer of support. I find it's very helpful.
Yeah, no, I agree. Again, I'm a little opinionated, but a lot of times I think that the patient and the family kind of decide a little too late.
Yeah.
The patient's really on hospice for a week, basically.
Right. It sometimes happens. Yeah.
I understand. It's that kind of acceptance that it's time to change the focus of care onto just alleviating symptoms rather than how would you describe it?
Well, it's to make the patient comfortable, and it's not to cure them but to comfort them.
Right.
I guess would be it in a nutshell somewhat. But they offer services to the family, and after the patient passes, they give bereavement services for a year. There's a lot of good things about hospice. And in home, try to keep them home instead of racing them to the ER for everything.
Right. And that's important. But, excuse me. No, I welcome it. And I think that too often the family and the patient, they decide too late.
I don't know if it's they decide too late or the services aren't offered to them in some way.
Might be part of it.
Mm-hmm.
Do we as a medical establishment not offer it, earlier as well, or
I think at the first inclination we will mention it because we can consult them and they'll come visit and see a patient and the family. But a lot of times patients say they don't want it,
right,
which is fine. They're not ready.
Not ready.
Absolutely. But a lot of times they say, well, tell me more about that. And so
it's kind of, we talked about how hard it is to have kind of the end of life discussion. So it's also hard to be the one that say,
yeah,
it's time, you really should consider this now.
Right. Right.
Unfortunately, it's only going to get worse for people. And if we need a plan to make their symptoms as minimal as possible and the remaining time as comfortable and meaningful as possible.
Yeah, right. I really think, just the years I've been in healthcare, I've really seen hospice services evolve, and they're really become more available in the hospital, whereas before it was just outpatient, we'll come to your home. But now, we set things up from discharge.
Right, there has been improvement with that.
Yeah.
And again, without getting into details, I had a patient over the weekend who was also a hospice patient, and the hospice nurse came to see her and gave some suggestions on how we could change some orders to improve her symptoms.
Right, yeah.
So.
I think just across the country, hospice services have gone up, the use of them, and in some places there's even like a shortage of hospice nurses.
Yeah, there was an article in the Times about that yesterday.
Yeah.
It's probably it's used a lot with cancer diagnoses, right? And it's but there are some other diagnoses that probably it's underutilized, like dementia.
Heart failure,
COPD, so that's just something to keep in mind too. It's not giving up; it's just changing the focus of care to minimizing symptoms and improving the quality of how someone's going to spend the rest of their time.
Right.
Yeah.
Right.
Yeah, definitely.
All right. So, what's your schedule like this week? What's your schedule like the week of a hospital? How many days on a typical week are you in the hospital?
3 or 4.
Yeah, I work 3 in the hospital.
And how long are the shifts?
12 hours.
All right. So you.
That's by choice, though. When
yeah.
I mean, when we first started, we worked 8-hour, 9-hour days, and I've always worked 12-hour shifts since I've always worked in a hospital, and I just prefer that. More time off. Right. When you're there, it's a long slog, as you know. But
it's a long slog.
A lot of times we're so busy, the days fly by. So that's a good thing.
Yeah, it gets tough at the end of the day because we're the only provider on between 5 and 7, and so we take all the ER calls and
floor
all
calls.
the calls from the floor and rapid responses. So normally, like your typical day at work, you would ramp up and then kind of quiet down at the end of the day, but it's kind of just you ramp up at the end of the day. So sometimes you leave and you're like, oh my God, what did I just go through? And but other times it's very it's fine, but sometimes it's very busy.
I'm with you.
Yeah.
You mentioned urgent care. Urgent care for me was a 12-hour shift, and the last 2 or 3 hours were the most stressful.
Yeah.
Because you're already there a long time.
Right.
Yeah.
And unfortunately, this may not be a surprise, but people kind of wait to the last minute.
They do.
So
yes, like in the afternoon. That's
right.
That's why it's so busy where we are between 5 and 7.
Some of it is just kind of like the day. It's probably starting right now. The ER is probably starting to fill up.
Mondays
are busy. I'm working tonight, by the way.
You?
We'll see how it goes.
Oh, good for you.
I just
either.
We're both on vacation.
We're not there.
All right.
You'll have some residents, hopefully.
Hopefully. No, that's fine. It's fine. And I'm okay. I've learned that when I covered the hospital, I go right over to the hospital. I'm sorry, after work, and it's just the way it is. But we'll be okay.
I'm sure you will.
Yeah, at least the hospital, compared to urgent care, is a 24-hour place. So there's always someone who's going to take over for you. So that's one thing that's very good.
That's right. So, do you feel that? What would you like in the hospital setting? Do you think, for example, when it comes to like specialty care, for example, we have a lot of we have a very healthy cardiology service. I'm wondering, because we all know that the Hudson Valley is becoming hot, and it's been challenging to recruit a lot of young physicians up to a place like here, right? They want to stay in Westchester or Long Island or Jersey or whatever. I'm just wondering if we're going to be able to be the beneficiaries of that, and maybe some younger physicians are going to say, hey, maybe I do want to work in Ulster or Dutchess County.
It would be nice. I think the pay is higher up here than it is in the city for physicians, so...
Something weird happens, right? Even though it's very expensive to live in New York City and around New York City, because the supply of physicians goes up, the payment actually goes down.
Yeah.
But there's exceptions to that. There's a wide variation. Same thing happened in Boston. I have a cousin who's a neurologist who left Harvard to work for a University of Texas, I guess, in Houston, whatever's in Houston. I wish I even know what med school it is. Maybe it's Baylor.
Baylor's in Houston, yeah.
Yeah, and that was part of the reason. I mean, because Harvard was like, well, we're Harvard, but it was,
Academic teaching centers are very much like that.
Yeah.
You're working for the name.
So he's doing much better in Texas, where the cost of living is less. And
than Boston.
Although it's Texas.
We're not going to impugn an entire state.
Not this show.
No. Although, I don't know if you remember, just a couple of years ago, one of the hurricanes, I can't remember which one came through Houston. And
Harvey.
Was it Harvey?
Harvey.
Well, you got a good memory.
Harvey, it was a terrible the flooding event.
And his street was kind of flooded.
Mm-hmm.
They were without power for a week or whatever.
Yeah, and then they had the ice storm.
Right.
Still feeling that,
Yes, the price of paint went up greatly because of that.
Price of what?
Paint.
Why paint?
I think I think Sherwin-Williams factory down there
A
froze
lot of factories, a lot of refineries, a lot of factories, and you just have to go there to see it.
Okay. So we're getting towards the end here. Do you have any things any thoughts that you would like to see over the next few years? That we can improve how we take care of people. That's a very open-ended question.
It is an open-ended question.
Well, I think things have changed in medicine a lot, like at warp speed for corporate medicine has probably made it difficult for the practitioners in the outpatient setting because they have such limited time with the patients. I don't know how that can change where you can get more time. And, the RVU.
The RVU, that stands for Relative Value Unit. That's kind of how we get measured and usually paid. So the more you generate, and by the way, the language we use is very uncomfortable. We refer to, a physician is referred to as a productive physician. One of our biggest producers. Really the choice, making it sound like we're
corporate language.
Yeah, my father was a shoe salesman. That's how he made his living. And yes, I'm sure he at one point was was able to kind of be in charge of the company, and he had sales people. Most of them were men, so they were salesmen to work. And yes, I'm sure he had high producers and so producers and low producers. But so that idea that business should be that medicine should be referred to in the same way, it's awkward, isn't it?
Yes, it's very awkward.
Did you always have really nice shoes growing up?
They're women's shoes. Right, actually, well, I think
your shoes are nice.
It was a very funny line when I got to college. We were all sitting in the first night of college. Tell us about yourself. And I remember, I don't know. And they said, well, what's your father do? And I said, well, my father's in women's shoes.
Oh, wow.
And somebody famously said, well, we didn't ask what he liked to wear. We asked what he was for living. So my father was in women's shoes.
Oh, so you didn't get to benefit? Well, maybe you did. I don't know.
No, we don't get the show.
When my brother got married, at the time Letterman was still a thing. And remember, he did the top 10 list. So the night before my brother's wedding, I was the best man. I did a top 10 reasons to marry my brother. And my brother was also in the shoe business. So the number one reason to marry my brother was free shoes. Oh my gosh, remember that? The top 10 list.
I love the top 10 list.
Yeah, I thought it was so funny.
Good show.
Yeah, no, I agree, and I medicine is getting bigger, right? And I say this to patients, and some maybe I'm frank with them, and sometimes maybe I'm frank to a fault. But I say, look, as the healthcare system gets bigger, everyone in it gets smaller.
Mm-hmm. Right.
Whether it's the patient or someone like myself, unfortunately.
Mm-hmm. Yeah.
So I guess it's incumbent on us to kind of not lose lose touch of the personal approach. But
I think that's a winning strategy. Yeah, absolutely.
I think we need to, look at it, stop referring to doctors as high producers.
Oh, I don't use that language.
Yeah.
No.
The quality
I don't
is
like patients equals consumers either. I don't like that.
Right, and we have talked about that. The healthcare as a commodity, it's somehow like it's akin to a restaurant. Are you happy with your service? I mean, healthcare is right.
Patients.
I get it though. I mean, they want to be
I get
treated,
it too. Right.
They want to be treated well. They don't want to wait an unreasonable time. That's very understandable. They want, but at the same time, it's not going to a restaurant. It's not how was your hamburger cooked.
Not at all. It's not the same thing. We shouldn't, false equivalency or whatever. It's just it's not the same thing.
And there's a disconnect. But frequently, what the patient wants or thinks they need is in conflict with what's the right answer. So that can sometimes lead to stress. Antibiotics are a great example.
Right. Also, we have Dr. Google out there, which is making things very difficult because everyone's always searching on I see that all the time where, knowledge is good, knowledge is power, but sometimes reading things on the internet aren't the best.
Yeah.
Right, and actually, I'm okay with that. Sometimes I'll say to the patient, "Well, what do you think you have?" And I'm willing to engage the patient, and I'll, sometimes they really get sent down the wrong hallway. Really.
Yeah.
I once had a patient request a medication for prostate problems because the patient had read that's the symptoms, and I said, "Well, you are a woman." And you do not have a prostate, so this is really not the right medicine for you. Yeah. It's interesting, though. The medicine is something called tamsulosin. You know what it is.
Yeah.
But now it is used for women.
Yeah,
a lot.
right.
So maybe she was right.
She was onto something.
It still makes for a funny story.
That is funny. That's great.
No, I don't mind when people do research. I want to inform a patient, but I want to be able to discuss, and if they're really, you talked a little bit about with the taking care of some COVID patients with ivermectin, when they really are asking for something that is just not standard, and
No, and when they say that it's, that's your opinion that we don't use it, that's just going down a really bad rabbit hole. That's
their research is you can gear your research on the internet to whatever you're looking for.
Right.
So if you want to get ivermectin, you can find research in quotes that says that it's beneficial, but it's
not.
It's not.
I had a patient a couple of weeks ago, a woman in her 60s, not vaccinated, doesn't want to get the vaccine, who asked me to prescribe ivermectin for her, and I told her not. And I kind of thought about maybe I should have, given her a little more tempered response. Saying that the evidence really is being studied, but right now it's just not something that's recommended, which is...
is that when you threw your cell phone and broke the screen?
I said to the nurse, "Where's a paper chart for me to throw?" No.
I need something.
Actually, the mouse. I have a mouse.
Okay.
Yeah. But she, so I declined.
Sure.
But she told me that her husband was having his physician prescribe it. So it was a physician in Rhinebeck, an alternative physician. So, that's frustrating.
It's very frustrating.
Well, my veterinarian prescribed it to my dogs for heartworm, so I was
going to say,
I have ivermectin in the household.
Have your dogs gotten COVID?
No, they haven't.
There you
See?
go. Do some research.
Yeah.
And they're not vaccinated either.
Oh,
wow. My
wow.
God, I've been wrong.
When COVID first came out, they were talking about it in cats. Remember that?
Cats. I think cats do get it. Yeah.
Right.
Well.
Yeah.
All right, so you're off for the week.
Kind of. Yeah.
I'm
doing the hospice work today, yes.
So now are you like segueing into another role, or are you?
This is just a per diem position, so just
Part-time.
Yeah,
Part-time.
just do it like maybe 1 day a week or so, maybe 2.
All right.
But it's just something that I want to do, something different. And that's a nice thing about being in medicine like this is you can change jobs and see something completely different. I've been doing hospital medicine now for 10 years, so it'll be great to do something different.
Interesting. Well, when's your next shift at the hospital?
Thursday.
Okay. And what about you, Jerry?
Next week. I'm not sure which.
Oh, you're off this week?
Yeah, I'm off this week too.
Any plans for your week off?
No. Doing this.
That was your only plan.
Can you come next Monday?
What are you going to do on your day off? I'm like, nothing.
I know, right?
I don't want to do anything.
Yeah. You stay busy.
Yeah. Well, we talk about that a lot. It shows up in the literature. The idea of downtime, is because it's better for you guys in a way because you're kind of doing the shifts. So when you're done, you're done. And I see you do a good job of like saying, "Do not disturb" on the paging system that.
Yes, that's a nice thing.
Yeah. People don't always listen to that though. They still will page you.
I thought that if it says "Do not disturb" and I send it anyway, you don't get it.
No.
If you hit priority, then it makes a terrible alarm sound.
Oh, because sometimes if I send it,
activated that too.
Oh, did you? Oh, I got to figure that out.
if I send it, I meant that it would be next time you kind of logged on, you see it.
Phone, it still shows up as there's a message there for
Really?
you.
No, mine doesn't.
Yeah, mine does.
Well, you
No.
got to deactivate
Catch
that.
All right, we are wrapping up this morning's show. How much more time we got?
Oh, you've got a beautiful 3 minutes, like a great hit song.
3 minute song. I was listening to the outtakes to the Let It Be album. That's the new thing with the Beatles. But anyway, interesting stuff. Briefly, in the time we have left, you got one of the important things that's important in the hospital setting is communication with the patient and communication with the family, right? Yeah. So what type of systems does the hospital have in place to kind of ensure that gets done?
Patient portal is very important.
So patients can log on to the hospital portal and kind of see what?
They can see, as soon as you sign your note, they can see your note that you've written.
Yeah.
And so patients can definitely, the families, if they have access to the portal, can see everything. We're supposed to call the families every day.
Right,
we have limited visiting hours now at the hospital due to COVID. It used to be 24 hours a day, but now I think it's from 12
6
to
hours.
6, and you have to be vaccinated to visit. So
nurses call the patients' families too.
Yeah.
Right. So that's sort of what I was getting at, was that Northern Dutchess really is assertively trying to make sure that the communication with not just the family, with the patient, but the patient's family, occurs.
Oh yeah.
Yes, it takes a lot of time, and the families are very grateful to hear from us. And we call.
In recent years, my father's been a patient at Westchester and some other hospitals. I've been on the other side. I mean, it's easy to kind of like not realize what it's like from the other side, to not even be part of what's going on, and so it really is a little eye opening to try to remember what it's like.
Yeah, it's always eye opening when you're you're the
definitely.
patient or the family of the patient. Yeah.
So I want people to know that Northern Dutchess Hospital is assertively, implementing that. I know the residents are
They call families a lot. Yeah.
And they document it. So we really have a system in place that the next of kin gets called on a daily basis with an update.
Right.
Right.
And that's a good thing.
It is a good thing.
Yeah, because it's a common, valid complaint, dare I say?
Right. Yeah.
What exactly is going on?
Right.
I remember when I was a medical student, I don't know, you would round early and who knows. And I remember as a student, they were like thrilled because you were the one that, even the residents weren't spending enough time with the patient. So the student really was the one really spending time.
Answer all their questions.
Yep, and that was mutually beneficial because you kind of like were, a pseudo sort of kind of might become a doctor. All right, so I want to thank Cherry and Laura for coming on the show. I think you guys
a pleasure.
Yeah,
you guys do a
you.
great job. Very proud of being part of Northern Dutchess Hospital.
Thank Thank you.
We give a shout out to our colleagues, Dr. Liz Levine, who is in charge of the hospice program, and Dr. Harizny, and Dr. Scadudo, and Dr. Masood, and Dr. Main, and Dr. Waltier.
Yes. It's all our full-timers, yes.
Yeah, and Dr. Hafez, who runs the family practice residency program, I just got a headline. I can't believe I'm saying this, but that that Colin Powell passed away.
Oh,
from COVID.
Did he?
He had COVID? Oh.
Wow. Yeah, COVID. He was 84. Well, that's
84,
interesting.
yeah.
All right. We'll see you in November. Robin will hopefully be here.
Oh.
All right. Take care.
All right. Bye-bye.
Thanks, guys.
Thank you, Dr. Eric Stanberg, and a very, very special thanks to our guests today, Lori Corriette and Terry Chazen of Northern Dutchess Hospital, nurse practitioners and hospitalist program. And you're with us here at KCR, and thank you for being with us this whole day, 7 to 9 a.m. That's our day here. And thank you for sharing Kingston Community Radio with us, AM 920, 92.5 FM, WGHQ, and our live streaming on mykcr.org. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. And we invite you to be with us tomorrow at 7 a.m. for a terrific Tuesday. And until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.